Translational Research's Enrichment Lecture Series. If we haven't had the pleasure of meeting, I'm Stephen Hardy. I'm a pediatric psychologist in the divisions of hematology, oncology, and bone marrow transplant. I'm also co-chair of the CTR Behavioral Medicine Research Special Interest Group. And our SIG is pleased to be co-hosting today's CTR Enrichment Lecture Series. So I'll try not to steal too much of Dr. Naar's time, but I do want to introduce her a little bit. So it's my honor to welcome our speaker, Dr. Sylvie Naar, who's a Distinguished Endowed Professor in the Department of Behavioral Sciences and Social Medicine at the Florida State University College of Medicine. She's also the director of their Center for Translational Behavioral Science and director of the university's KL2 program. Her program of clinical research spans translation of basic behavioral science into new interventions, randomized clinical trials, comparative effectiveness studies, and implementation science. Her work has focused on adolescents and young adults with HIV, obesity, diabetes, and asthma, and has addressed issues of behavior change, medication adherence, and substance abuse. I could get this wrong, but in my estimation, she has around 150 publications, and her research has been funded by HRSA and the NIH for the past 20 years, including several R01 and U19 grants funded by 5 different NIH institutes. I'm also happy to have Dr. Naar join us today because she is such a visionary leader in the field of behavioral science. I first heard Dr. Naar speak when I was a brand new faculty member here at Children's National about 7 years ago. I was attending an NIH workshop that she was facilitating on innovative study designs and methods for behavioral interventions to improve health. This workshop came at just the right time for me, helping open my eyes to the importance of building intervention work on basic behavioral research, but also forcing me to break out of my comfort zone methodologically. I had a chance to hear her speak again a year later at the American Psychological Association's annual conference, where she led a symposium on translating basic behavioral science into new interventions. I recall that this symposium was the first time that I had seen true community-based participatory research described from beginning to end, with community members playing a key role in the presentation of their results. It left a lasting impression and continues to remind me of the importance of keeping patients and communities at the center of everything we do, whether we are specifically carrying out a CBPR study or not. So I'm now so pleased to be able to invite Dr. Naar to take over and share with us her presentation titled Behavioral Interventions to Reduce Health Disparities in Adolescents and Emerging Adults.
Well, thank you so much. And it's nice to kind of come back to my roots, as I'm a pediatric psychologist as well, and that's how I got started in this work. Although as you move across the translational science, you of course integrate many different disciplines, especially public health, as we move on the implementation side of the spectrum. So today I'm going to just try to present an overview of my research over the last 2 decades and kind of pull it together with what we're working on right now. And for some reason now it is not letting me move my slides, which it did before. Okay, we'll see. Okay, so goals are dreams with deadlines. The goal for this next hour or 50 minutes is to provide you with an overview of health equity and health management, the concepts, talk about the spectrum of translational behavioral science, and give you examples from my own work with family-based interventions and individual motivational interventions, to talk about how we move from intervention development to testing to implementation and then back again. So this is a cyclical process. So you can see here that I'm very interested in improving equity, and we have healthcare covered. Sorry, this facility not accessible to the financially handicapped. I have spent my career working with marginalized populations and populations that often don't have access to the highest quality medical care. I started my work at Children's Hospital of Michigan, so children's hospitals are very much part of my heart. I don't know if you can see back here, I have this is my Children's Hospital of Michigan stained glass. And so in 2012, for the first time in history, more than half of the country's infants were minorities. So what was minority is quickly becoming a majority. But a review of 111 studies concluded that child health disparities are extensive, pervasive, and persistent. And unfortunately, there hasn't been as much movement as we would have liked over the last 2 decades. It's extensive in the sense that all 4 of the major ethnic minority groups have higher mortality rates. It's pervasive because it cuts across so many diseases and healthcare access and quality indicators, and persistent because it is not changing significantly over time. So how can poor health management help to explain pediatric health disparities? Well, health management is the term that we're trying to use now. It replaces the original terms of compliance. And then we thought we would do better with adherence. But if you look up a Webster definition, adherence and compliance still have this concept of sort of bowing down to authority. And then we have the term illness management, which was more recent, to really get a sense of all the different behaviors that go into managing. But we use the word health management because it's not just about managing your illness, but it's managing your health in a proactive way, and it includes the prevention concepts. So that's the term I've been trying to train myself to use more often. We know that the relationship between health management and health outcomes is stronger when we use objective measures. And so the other terms you'll see are measures of self-management, which we tend to utilize with older adolescents and adults, and family management, and coming out of the ASTHMA world primarily of how a family manages health and chronic conditions. We know that low income and minority families have more difficulty with health management for multiple reasons, which I'll show you, and that improving health management can then improve health equity. So if the relationship between health management and health equity and health outcomes is there, which it is, and when we look at objective measures, and we know that families struggle with health management, we can improve health equity by improving health management. So minority and low-income youth and families are less likely to follow medical recommendations across several different chronic conditions like diabetes, asthma, and pediatric overweight. Ethnicity and income are likely a proxy for many factors that operate within the individual family and healthcare system. This is an example of the social ecological model as applied to health management. I'm not going to go into detail, but if you Google search my name in social ecological model, you can see we've published on this model across a few different conditions in the pediatric world. But it basically goes through a host of different child factors, family factors, and community factors, and you can add to these based on the research you do that all get into health management and interaction between these systems. And so we took this model and we focused on adolescents and emerging adults. Why? I have always been an adolescent psychologist. I like to work with what people consider the toughest age group. Shakespeare kind of said, let's put all the people between 10 and 20 and lock them away. They have, adolescents and young adults have historically been the age group that make people tear their hair out. And so we know that health management deteriorates and risk behaviors peak in adolescence and emerging adulthood. Morbidity and mortality increases in adolescence relative to childhood in several conditions. The transition to adulthood is particularly difficult for youth with chronic medical conditions, but with great challenges come great opportunities. It's a time of rapid growth and change, and we can just shift that trajectory even a little bit. It's like the kerplunk game, one little shift can change the outcomes. So the anatomy of a teenager's brain, we know now that there's a lot of explanation of behavior that comes from this, where there's a rapid growth in the reward systems, but not as rapid a growth in the frontal cortex. And so, but it gives us a lot of opportunity as we can, again, intervene during this time of rapid change. So we've developed a program of research on translational behavioral science around adolescent and emerging adult health equity, and that still is the focus of my work here now that I'm at FSU. And so my work with the NIH, which was referred to in some of those earlier workshops, really was around taking this very strong translational framework that has been utilized extensively in the biomedical world and translating it for the behavioral world. And so in the biomedical world, the spectrum of T0 and T1 translation, where we take basic research discovery and we move it into new interventions, then those move into the bedside with efficacy trials and then move into public health. And so for behavioral science, there's now an Office of Behavioral Science and Social Research, which wasn't there when I had first started. Thank you to Norm Anderson, who really helped, was the first director of that office. And so if we we partner more closely with the basic behavioral and social scientists, we have an opportunity to really develop new treatments that are grounded in this very rich tradition of basic science. Those new interventions then move along into efficacy trials after they can show some preliminary effects and you've worked out all your kinks. And as I mentioned, I've been involved with models like the Orbit model that really get more into fine-tuning that early stage behavioral intervention development process with more rigorous methods. But then really important is how do we move those interventions out from our offices and into the world of public health for greater impact. So I'll give you a couple of examples, and I'm hoping that the gap will shorten as we've gotten better at different kinds of hybrid designs and with the focus on implementation science. But basically, very early on, in the early 2000s, we had worked with some developers of multisystemic therapy, which was an intervention that had been developed primarily for severe behavior problems such as conduct disorder and substance use. It was a family and community-based psychotherapy. The idea was that to find out what the barriers to whatever behavior you're targeting is to observe the behaviors where they occur. So we adapted the model to target what was then called adherence and now called health management. Difficult behaviors are viewed as multi-determined, and so they're not, the blame doesn't lie with the child or the family or the medical team, that they're very complex interactions. And because it had been used successfully in other clinical trials, we thought it was a good framework for us. And up until then, most of the interventions that were available were ones that had been tested in mostly Caucasian populations. And part of this was because pediatric psychology grew up in Gainesville, Florida. That's where the original conferences were, where there really just wasn't a lot of opportunity to engage diverse populations. Interventions were carried out in the community, as we mentioned, with very much a community approach. Caseloads are low, contact with families intensive, but time limited. Service provision is comprehensive. Therapists are meant to be available around the clock. It was sort of like the equivalent of wraparound services. And so therapists choose from a menu of behavioral interventions. This was not meant to be a one-size-fits-all. Here's my 6-session MI-CBT manual, cognitive behavioral treatment manual. It was meant to say, like, here are the very specific things we're going to assess for across the social ecological model. And here is where we match evidence-based treatments that were available to these different fit factors. And with my other work in motivational interviewing, we wanted to ensure that everything was delivered from a motivational interviewing foundation. And I'll talk a little bit later about what that means. But the communication approach was collaborative and autonomy supportive. So here's an example of an intervention grid of what kinds of interventions you might match to different areas of concern. So in the individual child, we might do some education and skills training, problem-solving skills, motivational intervention, stress management. When I say motivational interventions, this is written here twice because they could be intrinsic, which would be more around the motivational interviewing, or they could be extrinsic, which could be reinforcement. For the family, it was a lot of similar kinds of things, but also family communication training. And then if there's any mental health or substance use issues for the parent, we would be providing those or linking with services. And then with the community, we would actually go into the schools, have school meetings, to train the schools, find a champion within the school that could support the child. Family provider interactions would happen here, bringing in social support if it's a single parent who couldn't be doing parental monitoring, for example. Pro-social peers, case management for resource access. So the therapist would do all those things, but would match those services specifically to the unique needs of the family. So we've published now several papers that have shown the success of this intervention across several different conditions. So for our first foray was with adolescents with diabetes, and I put the reference here so you can get more detail. I'm not going to get into the detail of the stats for every study, since these are things that have been published for a while. But you can see that in the lower, there's no pointer now, I'm thinking with the Zoom, but you could see, I know there's a way to do it fancy with the computer, but I'm not going to try. From baseline to 6 months, in the lower dashed line, was a significant improvement in hemoglobin A1C with a very strong support condition where everybody got weekly phone counseling in the control condition. And while we did see some attenuation of effects at 12 months, this was still clinically significant. And then if you look cumulatively at DKA admissions over time, you can see a similar trend where the MST group in the lower line had lower cumulative DKA admissions. We then did a similar work and we adapted the model for adolescents with asthma. And here we focus exclusively on African-American adolescents for this study, where we followed 170 families over 1 year. The inclusion criteria were adolescent, African-American, and then these were considered high risk with 1 or more inpatient admissions or 2 or more ED visits in the previous 12 months. And yeah, I do put the reference here. We did see improvements in both in med adherence, as measured by the Family Asthma Management System scale, in lung function, and reductions in hospitalizations. So just to show you an example, this has been published in Pediatrics, that the MST group had significant improvements in FEV functioning, whereas the control group, which this time was a home-based weekly family counseling, like a Rogerian kind of non-directive counseling. So again, a pretty strong control condition that showed small improvements, but not to the as significantly as the MST group did. And this is at the intent to treat level. So our summary was that intensive home-based family therapy did improve objective health outcomes in high-risk youth with chronic illness. Reduced hospitalizations leads to cost effectiveness, and we did try to adapt this to the southern rural context in the HIV world. But what we struggled with was who's going to pay for this? And, you know, in this era of wanting briefer and briefer interventions, getting wraparound kinds of services for youth with chronic conditions can be tricky. Although there have been interest in it, but we haven't had, like for Medicaid, for example, but we haven't had buy-in to really pick up the model the same way. And we learned this even more the hard way when we moved into the area of obesity, which, you know, given the high rates of obesity in this population, who's going to pay for this kinds of services if, you know, 50%, let's say, of your population is eligible. So we wanted to look at a community health worker implementation to increase the translatability into the later phase translation. And so we wanted to know, can we distill MST in core elements? So while we had this lovely grid of all these different possibilities, did most families need a basic set of things? And so we were able to kind of go back and code what were the things that we did most often in the context of this flexible model. And what we learned was that we needed to establish therapeutic alliance, and that required and we utilized the motivational interviewing approach to do that. And we found some things like, you know, motivation was like associated with how often the parent showed up to treatment and other kinds of things. We knew that there was still a basic education that had to happen, and that, you know, what they were getting in the clinics wasn't always really resonating and sticking. And so they needed a more of a one-on-one education that could be adapted to cognitive level, to language, and all kinds of things like that. We knew that self-monitoring and parental monitoring were almost always an intervention that we needed to include, environmental control, organization planning, and then some sort of reinforcement or contingency management. And so we have taken these core elements, and we did an R34 with diabetes to look at the feasibility of this approach with community health workers. And we are working on an R01 right now for asthma. Of course, COVID did put a dent into that, as we were supposed to be working all home-based. But our completed trial with this approach was done with obesity. And so the Fit Families trial has been published in Annals of Behavioral Medicine, was a SMART trial, which is a sequential multiple assignment randomized trial that tries to build an adaptive intervention. And the way you do this is with 2 randomizations. And you basically, for our sake, we're starting off with less intensive and then adding intensity. So the first randomization is home-based, motivational interviewing plus skills, and using the core elements I showed before, those were the core skills. And we compared it to office space, because the first question we had was, do you really need to go into the home? We assume that home-based is better, but it is more costly, and there's sometimes safety concerns, and now with the pandemic, there's additional concerns. So that was question one. And then if you were a non-responder, and you can see, unfortunately, 3 months of intervention was not sufficient for most folks to lose enough weight, you would then get randomized into more skills or into some contingency management approach. So the voucher-based reinforcement approaches that are used extensively in substance use and have been used in the adult world with obesity, and smoking is another area where you see it a lot. Does the cost of that, is it kind of worthwhile? So we compared continued skills with a contingency and management approach. This was part of a U award that was around intervention development. So even though the interventions themselves had all been looked at in previous studies, put together in this way with a community health worker delivery was building a new intervention. So the idea of starting off with something less intensive and adding something more intensive. And so what we found was that treatment sequence did not really predict change of overweight overall, but you can see here that where you added contingency management, regardless of whether you started with home-based or office-based, and again, we weren't powered to really test nuances of differences. This is a developmental study. But what you can see was that across the board, the contingency management really seemed to be more effective if you look at the drops in percent overweight. And that was sort of regardless of whether you started in office-based or home-based. Where we did actually find a significant difference was in an intervention dose. And so you could see that the home-based dose was much better than the office-based dose, and the contingency management dose was much better than the just continued skills dose. So the idea is that as we build bigger, better treatments for obesity, people still have to show up. And when you're working with high-risk inner-city Detroit African-American families, they don't always show up. So even if you have the best interventions, you're not going to get anywhere if you can't get the dose of treatment high enough. And so again, the contingency management seemed to make a difference, as well as the home-based. And we also, a couple of other things we found out about is that skills utilization moderated weight loss. And so when we asked families about what skills they actually utilized, we found a significant difference with those who used more skills. So you can see the theme here of access, motivation, dose, use of skills, all that kind of stuff that we think about with treatment engagement is so critical here. We found a couple of other important moderators, which is really important to look at in developmental study. We found that older youth were more responsive to the contingency management. One of our I'll get to this in a minute, but also executive functioning. So those who had higher executive functioning and lower reinforcement value of food did better in the interventions, which makes us think about, do we need to go back to the drawing board and come up with some new interventions that improve executive function? So you could see the cyclical process. As we're trying to move towards later phase translation, we find places where new interventions need to be developed. And so that's one thing. So we do have some folks in the lab who are looking at other kinds of interventions to improve executive functioning. I'm a big proponent of physical activity because physical activity in and of itself improves executive function. We also wondered that the younger kids needed more parental involvement, and so maybe the CM needed to target the parents too. The CM did reinforce the parents for coming to session, but not for doing anything. So we have a new R01 that we're just about to get at the notice of award, where we're going to take the intervention and we're going to add a physical activity component, like a direct physical activity where we work out, with the parent and the youth and teach them how to work out on their own with using resistance bands and body weight exercises. And then we adapt the CM to target the parents. So the parents get reinforced for their own step counts and for self-monitoring their own food, with the idea that we'll increase modeling of behavior. And so that is our current R01 that we'll be getting started shortly. So the summary of this work is that it did feel like if we combine MI with some core elements of CBT around self-monitoring and parental monitoring, potentially adding a contingency management component, that we could deliver the interventions with community health workers. So the Fit Families, maybe it wasn't clear, but we're all community health worker delivered. But they require extensive supervision. So our PhDs and, you know, MSWs are not out of a job. They have to supervise very carefully and closely the community health workers to deliver interventions with fidelity. But I started thinking, you know, as I've worked across so many different conditions now, that this is kind of like a transdiagnostic treatment approach, that if you take MI combined with the core elements of CBT, focus really hard on, you know, engagement and access, that we may have a transdiagnostic treatment. And so this is one book that I have out that shows how this MI-CBT approach could be utilized in different ways. And so the approach is, there's several cases that are followed throughout the book that include mental health, substance use, smoking, medication adherence. So that will help with translation, because instead of having to teach a community health worker 5 different kinds of interventions in the real world, where they may be having all different kinds of cases, they could be utilizing a similar treatment approach. So that brings us to the next area of my research. So that's all with younger adolescents. And so you can think about how with the younger, when I say younger, I mean, it was 12 to 16, those were all family-based approaches. But in my other line of work, I was also working with emerging adults. And most of the emerging adults I was connected with from the inner city were not in very strong family systems where family interventions would make sense. So my other text is Motivational Interviewing with Adolescents and Young Adults, and the second edition will be coming out in July. And so this work came out of primarily my work in HIV. And what you can see here is the cascade of HIV care in the United States. And I have worked, Children's National is one of my sites with Larry D'Angelo. And what you can see is that this is a little bit old now, but it's still a concern that the youth tend to drop off what we call the treatment continuum. So when we look at the percent that are modeled to be infected and how many actually get diagnosed, how many actually get linked to care, retained in care, and become virally suppressed, that the numbers are quite dismal. They're a little bit better now. We have done somewhat better, but they're still not sufficient to control the disease. And what the references along the top show you are the different ways that we've used motivational interviewing at each point in the cascade. And so this made us feel pretty strongly that motivational interviewing in a structured format, each one of these had a slightly different format, could be useful across the cascade of care. So what is motivational interviewing? I said I would get a little more specific about this as I moved along. It's a method of communication. So it's not a structured intervention in and of itself, although it can be. It's a method of communication designed to increase intrinsic motivation by eliciting and reinforcing change talk. It's very specific in the sense that we can code every word that the provider says to see whether it's consistent with MI or not. But it has been utilized in a more structured intervention called motivational enhancement therapy, where they take 4 sessions of MI plus some implementation, intentions, and goal setting. Came out of the alcohol use field, and has been adapted for many different kinds of behaviors. There's been some meta-analyses that show the approach is particularly effective with minority adults. And then there were some more recent meta-analyses for adolescent substance use and pediatric health management. So to show you the span of translation for this population, I started off my work too long ago, but doing with a NIDA R21 that adapted the motivational enhancement therapy to target multiple risk behaviors. Sexual risk, youth could pick 2 out of 3, sexual risk, substance use, or medication adherence with youth living with HIV. Then that was called Healthy Choices. And then we, in 2005, we did our first RCT of Healthy Choices, where we found significant improvements in adherence, sexual risk, and substance use for different, for those who had risks in those areas. We moved then to an effectiveness trial, which is the T3. So T1 is the early phase intervention development. T2 is your RCT. T3 is now using real world providers, so clinic-based community health workers, and then we randomized to community-based, which is again in the home, out in the home or community, or office-based. And I'll show you those findings in more detail. They've just come out now in JAMA on Open Network. So one thing that was important to pay attention to is in the time it took to do the original trial to the second trial, and I was raising babies and doing other things in between, there was a difference in the epidemic. And so the epidemic became more an epidemic of young men who have sex with men. It was always affecting minority populations most strongly. That hadn't changed, but you can see that it had become more biologically male, or male to female transgender, and non-heterosexual. And what you can see here is also that drug use became a little riskier. So in 2005 to 2007, the original trial, we had high rates of marijuana use, somewhat lower, but still high rates of alcohol use, and quite low rates of other drugs. But in 2015, we had much more polysubstance use. So 30% of the population of the study population was now using multiple substances. So alcohol, marijuana, plus one other one. And that really was, I think, the result of the infusion of club drugs, but also stimulants like Ritalin and other kinds of methamphetamine and opiates. So there's something to think about as you move along the translational spectrum, that even though we were still targeting like academic medical centers theoretically, clearly that we were still reaching very high risk populations. So this just shows you the consort statement. As I mentioned, this has been published now out in JAMA. What you can see here is that the follow-up rates were a little bit lower than what we had in the first trial. And again, we attribute that to just being, again, a higher risk population. So that's just down below, that shows you the follow-up rates were more like 65%. And I think before they were closer to like 80 to 85%. Luckily, we had way more advanced statistical methods 10 years later to account for missing data. So for data analysis, the viral load data were gathered from electronic health records taken from clinic visits. And then the adherence self-report was a visual analog scale, and we used latent growth curve modeling to look at between condition differences. So what we found was that, remember, both groups are getting intervention, and by the same people. The only difference was home and clinic. And so part of it is looking just across the board about whether we had any change. And so we were pleased to see that our primary hypothesis of just healthy choices, period, pre to post, did make a difference with this very high risk population. And so you can see the average log viral load, while still not undetectable, these were kids that were all not adherent at baseline. But the interesting thing was that the clinic-based ended up doing better across the 12-month trajectory than the home-based. And so that was counter to our hypothesis and counter to what you saw in the adolescent trials that I described. It was similar when we looked at percent undetectable. So again, remember, 0 were undetectable at baseline, and now we've got 40%, undetectable at 8 months in the clinic group. 35% lasted till 12 months. This was a 4-session over 3-month intervention, pretty brief. And we found similar findings for alcohol use. This was an MI-CBT study, so that was our main secondary outcome, and adherence. Interestingly, perceived stigma improved in both groups, that the MI approach seems to have an impact on perceived stigma, and that is seen in the substance use setting as well. So what does that mean? Oh my goodness. Well, I mean, I was a home-based delivery person forever, but I think, what it's telling us is emerging adults might be different than adolescents. And so doing home-based work is just very different in an emerging adult. And then we were dealing with emerging adults that were not only ethnic minorities, but tended to be sexual and gender minorities, and who were probably, we know, not as tied to family, but also not having stable housing. So young sexual and gender minority adults have a very hard time with housing. They're often kicked, not in family homes because of being kicked out, or once they're disclosed their sexual orientation, or they may be living in very risky environments, and they don't want, and if you have HIV, you don't want whoever you're living with to know. And so even if you meet somewhere else, like the library or McDonald's, it's just not a safe space. There may be like a Hawthorne effect of being just randomized to a clinic space and having to come to the clinic for your intervention session, where now suddenly you're like, oh, that wasn't so bad, and now you're more connected. We didn't see a major difference in appointment attendance, but there still could be just something about coming to the clinic that made the difference. So now it's like, well, how do we improve access to these interventions? Because most of the kids still only got 2 out of the 4 sessions. So our question is, well, maybe they only need 1 or 2 sessions if that's all they end up getting in these trials. So we're going to look at a SMART trial to get to figure out, like, okay, is 1 session enough for some, and then some need more? So the SMART trial is like the sequential multiple assignment trial I showed you before. And then the other is what else can we do to look at alternate delivery models? And now we're going to be comparing, well, this is what we've proposed. We'll find out if we get funded in April, but comparing telehealth versus mHealth. So an app completely versus telehealth or video conferencing. So that's our next step. We've submitted a grant to do these first 2 points. And then we have some people working on adapting healthy choices for international settings. So a Thailand pilot has been completed, and we're proposing one in Zambia. So that would be more translation. In terms of computer delivered, I just wanted to mention that we do, and I believe Children's National is a part of the study as well. We do have a 2-session computer delivered MI that's sort of based on healthy choices that we piloted for youth newly starting medications. It's a super brief intervention, and I was really skeptical, but the idea was if you target youth at a critical period, like just when they're starting meds, which is that you're more likely to get a bigger bang for your buck with brief interventions. And we did find in our pilot, and this was published in AIDS Care, that youth receiving MESA, which is 2 sessions of this motivational program targeting, this is fully app, no person interface with a virtual counselor, targeting adherence, did better than the same. We had, again, a very strong control. It was the same program, but targeting diet and exercise. And we seem to show, this is again, signals of effects on adherence, on starting medications, and on viral load. This is now being tested in an R01. So we have a full-scale R01 that's just being completed. This motivational enhancement system we've piloted for emerging adults with asthma, for caregivers with diabetes, and then we have a pilot pragmatic trial to embed this motivational intervention to improve retention and care and prep services. So that's kind of where we're headed with that, is just trying out different, I'm kind of sold on MI and CBT based interventions with maybe a contingency management on top, but figuring out how to translate it so it can get best into the real world. How much effect do you lose by delivering it via technology versus how much do you increase with reach? So the message that I've always been told is public health equals, the public health impact is effectiveness by reach. You can have the most effective intervention in the world, like maybe the MST intervention, but if you can't get it out to people, the impact is low. You can have a very low effect intervention, small effect intervention, but if you can get it out to millions of people, right, then the impact is quite high. So I like doing both because I think both are important, both the higher intensity, lower reach, as well as the lower intensity, higher reach. And maybe, at some point we'll get to more head-to-head comparisons. So I'll leave you with my heaviest duty work in implementation science. And for those of you who are newer in your career or thinking about transitioning to different kinds of topics, I should tell you that I was rejected from like the NIH Implementation Science Summer Institute, and I was rejected from all these different things that I was trying to learn implementation science. And finally I gave up trying to do a course, and I said, I'm just going to start submitting grants and learning myself. And so I had, at least 3 or 4 failed grants until finally I got an but I learned every time, and I was learning more about implementation science. And then I finally got an R34 funded And then that moved into a U19, all based on implementation science. So I currently have a U19 that's addressing hybrid trials to study effectiveness and implementation simultaneously. It's called Scale It Up. It's within the Adolescent Trials Network for HIV/AIDS. If you look up my name and Scale It Up, you'll see a whole supplement that describes all the different studies in that U19, but they're all based on effectiveness implementation hybrids. And so we have a telehealth intervention that's primarily looking at effectiveness. We have a MI-based intervention for sexual risk reduction, and which is condom use and PrEP. And that's going to look at effectiveness and implementation equally. And then we have my study, which is a type 3, which is looking at how do we actually train providers in multidisciplinary settings in motivational interviewing. So it's one thing to be a pediatric psychologist who can go through all this training and get supervision, but how do we get everybody from the office staff all the way to the physicians to be able to provide and communicate in a motivational interviewing fashion. And so here we went back to the basics. And so we utilized very basic communication science methods. And we actually had youth living with HIV carry recorders in their clinic. And this was in Detroit. And we coded them. And we wanted to see, are there core communications that are consistent with motivational interviewing that were most predictive of what we call change talk or motivational statements on the youth. So, we know that it's not going to be realistic to necessarily train all disciplines and all the parts of MI to deliver with perfect fidelity, but what are the core things that are really critical? And so you can see we did this, these are the encounters, and we had 35 medical ones and 34 psychosocial ones. And we had this extensional coding system that we had originally developed for obesity, and we adapted for HIV. And so we coded all the different provider communication behaviors, and then we coded the youth change talk. This has been published in Journal of Developmental Behavioral Pediatrics originally, and then the HIV version was published in AIDS Care. And you can look at the probability of when a provider says something, what's the very next thing that the patient says, and you can analyze that probability. And so what we found was that the first thing we found is that questions that elicit change talk directly, so not all questions, but only questions that elicit change talk directly, change talk again are motivational statements on the part of the patient, were most strongly related to getting change talk. But interestingly, it didn't matter whether those questions were open or closed. So now I don't have to spend an hour teaching physicians how to do open-ended questions when really, the closed-ended ones, maybe they're not the best change talk. They might not elicit the richest change talk. They might not get the most, but they're still effective. So when will you talk to your partner about your HIV status? Or what ideas do you have about talking to your partner? The more you reflected the change talk, the more you got change talk. So not any reflections. Originally, people were taught in MI to reflect everything. And then people would get I sound like a parrot. That doesn't sound right. Now we're just reflect the change talk part. So you could say I'm sorry you're feeling this way, or you don't have to ignore the bad stuff, but you want to reflect the change. You're worried that missing meds will affect your health. And then affirmations were still relevant, although again, not the strongest. So if you have certain staff that are just not that good with affirmations, I'm not going to tear my hair out trying to teach them how to do it, So this is kind of how we adapted. When we looked at counter change talk, which is the opposite, which is I don't want to take my meds. I don't need to. I don't have to. Why should I bother quitting smoking weed? We found that reflections of ambivalence actually led to more counter change talk. And this is where we okay, don't teach people to reflect everything. You can actually do more harm than good. And then if you actually asked an open question that elicited counter change talk, that got you more. Why don't you want to come to appointments? Do you need to keep smoking right now? And then if you reflect the counter change talk again, you can get more of it. You don't want to use condoms because you don't like how they feel. So this was really, really important work for us because this is going back to T1 so that we can improve our training and get back to T4. And so what we did is we developed this tailored motivational interviewing, and it's a very specific kind of MI training. And what we did is we utilized real world examples. And we now had all this rich information from these transcripts that could use real examples of how young adults with HIV, as well as adolescents with obesity and their parents, because we did this in both studies, found similar results, by the way. And we could teach about motivational language first. So traditionally in MI, people talk about reflective listening first. We learned that what people learn first is what they hang on to. So if you try to teach someone reflections and then later on you want to teach them, don't reflect this, just reflect that, doesn't work as well. If we start off with, here's what change talk looks like, here's what you're listening for, and then we teach them to reflect it, things go better. We only teach reflections and questions in the context of change talk. Again, we practice it and learn it that way, and we don't teach reflections in response to counter change talk. Instead, we talk about expressing empathy and supporting autonomy. I didn't get into this, but the whole concept, we have developed a whole coding scheme of communications to support autonomy. They are things like emphasizing personal choice. You know, we can all tell you the best way to manage your diabetes, but ultimately it's your choice about what you want to do when you leave this room. Emphasizing personal responsibility, like you have a plan, so you can let me know how that plan works out. And if I'll, you know, which that's usually if the plan is not consistent with what you want, you let me know how it works out, and we can, you know, we can always tweak it when you get back. So those are some things that we're working on now in terms of really getting into the supporting autonomy more so. So in summary, you know, you can see from a career standpoint, you know, kind of basic science, intervention development, moving to implementation, but optimizing and always going back to improve our interventions is kind of how I see the work. And of course, it's not all me. I couldn't have done it without fantastic collaborators. And in response to the community engagement, we have a youth advisory group that is partners with us side by side across all of our interventions. This is the youth advisory group for Scale It Up Florida, for Scale It Up. And then we have developed a new one for Florida, where we're getting youth across the state of Florida, now that I'm here, for another separate Florida-focused youth advisory group. So the next step for me is to try to do some interventions that are statewide. And then the state has partnered with us to share their data in the HIV world as for outcomes. So you can actually now look and see, like, can our behavioral interventions get scaled up, get rolled out with fidelity, that's the biggest challenge, and have an impact on the statewide numbers for youth and HIV epidemic. So thank you. On that note, I will stop and take any questions.
Thank you, Dr. Naar, so much for that wonderful presentation. I do want to open it up for questions. I think about midway through, we did have one question from Dr. Herbert, who I think this was in reference to some of the work you were sharing about the differences between office or clinic-based interventions versus home-based, and she was curious how you would categorize telehealth. I know that's something that we're all thinking about.
We are trying to think of telehealth a little bit more broadly. I think we haven't tested telehealth yet. We have one intervention for transgender youth that we are testing it. What I have found is that we offer youth a choice of phone or video, because we originally tried to do video because we knew, you know, like all the nonverbals and all that kind of stuff. But the youth, the providers are telling me that the youth do not like doing the video. They don't like to have to, you know, put themselves together. They may not be in a safe space where video is comfortable. And so we're now doing choice in terms of the format. I'm not sure if that answers the question, but that's kind of what where we're at, is we tell them, like, video is great because we can actually see you and you can see us, but it's your choice if you would prefer audio only.
That makes sense. Thank you. Linda, did you have any follow-up questions related to that?
Hey, thank you. Sorry, I've been navigating lunchtime with my daughter while listening, but taking many, many notes. So thank you for this talk. Yeah, to follow up on my question, I guess I was thinking, like, when you're doing the home-based work, I'm wondering, since I'm not very familiar with MST, like, what aspects that are, you know, occurring in the home do you think it is that are affecting the intervention that maybe aren't necessarily happening in the office space? And I'm wondering if use of video and the telehealth by bringing you into the home is in any way able to somewhat replicate that, or I know there are limitations.
Yeah, I think that in the study that's going on for the asthma study, I think that's what they're doing. You know, they held off obviously when COVID first hit, but now they're like, we can't like just, you know, stop. So that's what they're doing now. Is so, for example, we had this little measure called My Pantry, where we would go into the pantry and like code like what this is for the obesity, like what food was in there. Was there any, you know, was it all convenience food, processed food? And so that kind of thing I would imagine you could do with a video. So I do think that we're going to be forced to be more creative, you know, with what we're going to be able to do intervention wise. And for the Fit Family study that just got funded, NHLBI, you know, basically was like, you have to, we're not going to give you the funding unless you could figure out how to do this via video. And so we're going to actually be trying to do the physical activity training, you know, via video, which, as any of you who are been doing any of the open fit and beach fit, I mean, there's so many of those, you know, going on now that I think people are getting more used to it. So the silver lining with COVID is I think it has forced us to try alternative delivery models, and then it also forced families and adults and, you know, to get more comfortable with these alternative delivery models. You know, it's rare now to find someone who hasn't done a Zoom birthday and a Zoom, you know, so people are getting more used to that, which really has advantages, because as I move statewide in Florida, Florida is a huge state, but has massive amounts of rural setting, you know, components, and the sexual gender minority youth in those areas are very disenfranchised. So we're really using this as an opportunity to reach out to those youth as well.
Thank you. I appreciate that.
Yeah.
Does anybody else have questions? Feel free to just unmute yourself and speak up. But you can also just type in the chat if you'd rather that I pose the question.
Okay. All right. Well, I think I meet with some of you again at 4. Is that right? Or I get back on at 4. So we can talk then.
Could I just interject a quick question? I typed it into the chat, but
oh wait, okay, I didn't see it.
didn't know it. Yeah, this
Go
is
ahead.
Adam Richman. I'm curious if there have been efforts to implement some of these interventions to adolescents who are in juvenile detention facilities, and whether they prove effective, you know, after these individuals go back out into the community.
It's amazing you're asking me this. So you know, the original MST was done with juvenile detention populations, but wasn't focused on health behaviors, right? So the answer is the model worked, but it hadn't been focused on health behaviors. I have been, I don't know if it's the, you know, everything going on in the last year, but has really wanted me to work more with justice involved populations. And we also have a phenomenal justice center upstairs. So we are actually piloting right now. We're just about to start recruiting for MI plus physical activity plus navigation intervention for young adults re-entering the community from, now this is young adults, so it's not actually, I mean, some of them are detention turned 18, but some of them are jails, prisons, or probation. Young adult African-American males. And so so I'll let you know, when I come back. We're piloting it, and we're going to use the MI, we're going to code the MI sessions qualitatively also to kind of get a sense of what the young people want.
Yeah.
And I'm really excited about it. You know, interestingly, when we looked at the some of the data of the ATN, of just their general polling, baseline data from anyone who shows up to clinic in 3 months, 30% had criminal justice involvement. You know, it's in part because you're dealing with a primarily minority population, because a lot of the sexual and gender minority youth get themselves into trouble because of survival, things they have to do to survive. But I was like 30%, and we hadn't even really addressed this. And we know that some of the trauma stuff that's coming up in that population is probably related to that as well. But it's definitely something that I'm gonna probably spend the next 5 years of my career kind of thinking about and getting more involved in.
Thank you.
Thank you.
Thanks. Any last questions for Dr. Naar? All right. Well,
All right.
so much.
Thank
We
you.
really appreciated you taking the time to share your work with us.
Oh, yes, no problem.
All right.
All right, I'll see you soon.
Thanks so much for joining,
Bye-bye.
everyone.